So mitral stenosis, a narrowing of the mitral valve orifice, and the normal valve size is about 4 to 5 centimeters squared, and it's one of the larger valves. And as a result of that, the flow is somewhat slower than, say, through the aortic valve, and that is why, if you have, say, a mitral prosthetic valve, the chance of clotting is greater across the mitral valve and the tricuspid valve than, say, the aortic valve, because the valve area is larger, so therefore the flow velocity is going to be less. Remember, flow is a constant number, and flow is the product of the cross-sectional area times the velocity. So if the area is large, the velocity is going to be lower. So slow flow, it increases the chance of clots. Just one of the causes. So what are some of the causes for mitral stenosis? Everybody know rheumatic heart disease, rheumatic fever, and that's very common in the tropical, well, not really tropical, but third world countries. Rheumatic mitral stenosis, very, very common. Senile degeneration, that means the older one gets, the valve become calcified and restricted, and you get some amount of mitral stenosis. We see a few cases, not a lot. By far, rheumatic mitral stenosis is the most common. You can also get infective endocarditis with scarring of the valve, and as a result, the valve becomes stenotic. And tumors can restrict the opening of the valve. So what are some of the signs and symptoms of mitral stenosis? So again, remember, the mitral valve is not opening properly. As a result of that, the blood backs up into the left atrium, backs up into the pulmonary venous system, so the patient presents with shortness of breath, first with exertional shortness of breath on exertion, then they can't lie flat, they're orthopnic, and then when they go to bed, they have to jump up and sit up in bed to breathe, PND, paroxysmal nocturnal dyspnea. Patients with mitral stenosis, if they tell you that they have palpitations, you have to think in terms of atrial fibrillation or atrial flutter until proven otherwise, and that's a very bad combination, because that combination can cause the patient to decompensate. So, these patients tolerate increased heart rate poorly because it increased the gradient across the valve and increased left atrial pressure and all that sort of stuff. Sometimes the patient can present with chest pain, but it's not the chest pain that, we coronary artery disease. That's not that type of chest pain. Hemoptysis, because the pressure from the increased left atrial pressure, increased pulmonary venous pressure, you have increased capillary pressure, so you burst the capillaries in the lungs, and so these patients can cough up blood. Hemoptysis. Thromboembolism is huge because you get stagnation of blood in the left atrial appendage and also in the left atrium itself, and the left atrium becomes very large. So these patients can develop thrombus, and these thrombus can break off and embolize. So, that's another big thing. Ascites, and that's just from the backup of pressure. Again, increase pressure in the left atrium, increase pressure in the pulmonary venous system, and that goes into the pulmonary arterial system, and you have increased pulmonary pressures, and patient can develop with engorged liver and ascites, leg edema for the same pathophysiology. The murmur for mitral stenosis is a diastolic murmur. So remember, the mitral valve is not closing properly. So when blood flows across the mitral valve, it's going to make a sound, and we call it a diastolic rumble. And one of the things we use to gauge the severity of the mitral stenosis is something we call the the S2 open and snap interval. So remember, the S2 is, S1 is when the mitral valve close, and S2 is when the aortic valve close. When the aortic valve close, it signals the onset of diastole. It signals the onset of diastole. So when you hear S2, that's the beginning of diastole. And then if you hear that open and stop, the valve trying to open, that interval gives you an indication of the severity of the mitral stenosis. The smaller that interval, the more severe the mitral stenosis. So this is what we're talking about. So this is a parasternal long axis view, and you can see the anterior mitral leaflet and the posterior leaflet. If you look closer at the anterior mitral leaflet, you see that acoustic configuration. And the reason why you get that acoustic configuration is because of the commissural fusion. That's a hallmark of rheumatic valvular disease. You get commissural fusion, so you get this acoustic configuration. I don't want to say it's pathognomonic, but when you see it, it's like 99% sure it's rheumatic mitral valve disease. So it's the anterior leaflet, acoustic configuration of anterior, that's because of commissural fusion. Okay, and then the left atrium is usually large. So you measure it, usually get a big left atrium. When you look at the mitral valve on echo, because you get this commissural fusion, the mitral valve have a conical shape. So you have to be very careful when you're doing planimetry. You don't want to, as a cone, remember, a cone has a narrow base and a narrow top, and then the base is broad. So you want to get the most restrictive portion of the valve, because that's going to tell you how much obstruction you have. So you have to scan down until you get the smallest area. Again, four-chamber view, looking at the heart. So this is your left ventricle, your left atrium. So the left atrium is huge, and you can, well, you can see that there's restriction in the opening of the mitral valve. Mitral valve is somewhat thickened. In this four-chamber view, we talk about subvalvular apparatus. So this is the valve, and when we say subvalvular, what is underneath the valve? So you have the cords, mainly the cords, and what we look for is chordal thickening, chordal shortening, and calcification. So you have to talk about what's happening to the subvalvular apparatus, and then you also talk about what's happening to the valve. Is the valve thickened? Is the valve calcified? Is the valve mobile? Yes or no? So you have to describe all those features. Okay, so you're looking at in diastole, systole. Okay, so how do you assess the mitral valve? So the valve is going to look like it's not opening properly. It could be rheumatic. It could be senile. Rheumatic is far more common than senile mitral stenosis. One of the things you're going to do gradients. And in order to do gradient across the mitral valve, you have to use continuous wave Doppler. So the first thing you're going to do is your two-dimensional echo. Of course, you're going to look at the valve, and you're going to talk about the anatomy of the valve. You're going to describe that. So you measure the gradient, and we use the mean gradient. If the patient is in atrial fibrillation, you use 5 cycles and you average it. If the patient is in sinus rhythm, they use 3 cycles and you average. This is no longer, this is the old criteria, so we'll just skip that. Okay. So if the patient is in atrial fibrillation, so these are the diastolic, the mitral inflow. These are diastolic envelope, A, B, okay? When the mitral valve opens, blood flow across the mitral valve, and if the patient is in atrial fibrillation, then all the envelopes are they're gonna look different. If the patient was in sinus rhythm, then these diastolic envelope would be sort of similar, but in atrial fibrillation, they look different. So that's why you have to gradient across 5 of them, and then you average it to get the average gradient, okay? Planimetry, the limitation of planimetry, as mentioned before, the valve is somewhat, when it's the commissural fusion, you get a conical shape of the valve. You want to get that, the most restricted area, so you're going to scan down until you get that little, the tip, okay? So going to do that in the short axis view. You're going to scan from apex to the base to ensure that the area is measured at the leaflet tips. You're going to zoom. When you're doing any measurements in echo, remember you have to zoom. So again, the base, the tip, this is the most restricted area. So this is what you want to measure. Again, we showed you that before. You want to measure. Okay, so there are a number of methods to assess mitral stenosis, the area. And one of the methods is the pressure half-time area, the pressure half-time method. The Dr. Little, Dr. Little, who worked somewhat, did some work at Mayo, came up with this formulation, this formula, that the mitral valve area is 220 divided by the pressure half time. That's the time it takes for the pressure to fall to 1/2. So you did a series of experiments and came up with this. This is more so for rheumatic. It works very well for patients with rheumatic mitral stenosis. So 220 divided by the pressure half time. So sometime when you do your pressure half time assessment, you get a sort of mitral inflow envelope. You get something looking like this, and then you wonder, where do you put your cursor to get the pressure half time? So you're going to right at this flat portion. You don't do it at the beginning. This is where you do it. So this is the correct way of doing it. Okay. Remember, if you do the slope, okay, and you get deceleration time, remember pressure half time is 0.29 times the deceleration time. So you have to always have these little numbers in your head. So it is the time it takes the pressure to fall to 1/2, okay? So it's the actual patient. So these are diastolic envelope. This patient is in sinus rhythm. So you see the envelopes look similar, but basically this is where you want to put your cursor right there, and you'll get the pressure half time. So the formula is 220 divided by the pressure half time. The machine will give you either the deceleration time or the pressure half time. So the pressure half time is the pressure half time is yeah. So the pressure half time is 0.29 times the deceleration time. Okay. All right. You can also use the continuity equation, and it's the same thing that we have been talking about forever. The flow across all the valves are the same. So the flow across the mitral valve, which is the mitral valve area, times the TVI, time velocity integral, is equal to the flow across the LVOT. The flow is going to be the same, okay? We can calculate the flow across the LVOT because the flow across the LVOT is remember, you have to remember these things, 0.785 times d squared times the TVI across the LVOT. D is the diameter, okay? So, and when you do your mitral inflow, you can trace the TVI. The only thing you don't know is the mitral valve area. So if you just rearrange the equation, you can get the mitral valve area. So, you know, be familiar with that. Okay. And we're not going to, but you can use a pizza method as well. We're not going to, we'll look into that in another time, but you can use a pizza method as well. Again, you're gonna, with two-dimensional echo, you're gonna look at the valve, and there are a number of features we use to determine if the valve can be repaired. And which when we talk about repair, we talk about mainly percutaneous mitral valve commissurotomy, or you basically just crack open the valve. And we have a scoring system that we use for that, okay? So this is the scoring system, the so-called Wilkins scoring system. And we look at the mobility of the leaflets. We look at the thickening of the leaflet, and we look at the calcification of the leaflet and the subvalvular thickening. So there are four things that we look at to determine the suitability of the valve for balloon commissurotomy. Okay, you can just put a balloon. So this is a percutaneous. There's a percutaneous approach where you go up into the you go through the inferior vena cava. You enter the right side of the heart. You do an atrial puncture. That is, you puncture the atrial septum. You puncture the atrial septum, and you go across the mitral valve, and you just blow the balloon up. So the suitability for that procedure, we look at the mobility of the leaflet. Okay, if the leaflets are highly mobile, they get a score of 1. If they're very restricted and minimal forward movement, 4. You look also at the thickening of the valve. And if the valve is close to being normal, you know, then you get a score of 1. If the leaf they're very thickened, greater than 8 to 10 millimeters, then you get a score of 4. And then you look at calcification of the valve itself, just a small area of calcification, 1. If you have extensive calcification, 4. Then remember the subvalvular apparatus, the cords essentially. So you're looking at the thickening of the cords, and then if it's just minimal thickening, 1. If you have extensive thickening and shortening, then 4. Suitability, you want the score to be close to 4. A score close to 4 say that the patient is a very good candidate for percutaneous valvuloplasty. There are a couple, there are one thing that is not in this table is the mitral regurgitation. You want the patient to have not too much mitral regurgitation, but less than mild mitral regurgitation. Okay, and of course they can't have any blood clots in the left atrium or the left atrial appendage. So those are additional things that you don't want the patient to have. So the Wilkins score, we usually talk about a score less than 8 being suitable for percutaneous balloon valvuloplasty. So what we're going to do is we're going to look at the the '09 guidelines, work very well, but what we have realized is that some patients that we call mild mitral stenosis were very symptomatic, and especially if you exercise them, they become very symptomatic. And then there is a group of patients who, have very significant stenosis, so we classify those as very severe. So in 2014, the American Heart Association, American College of Cardiology, they released a revision to the 008 guidelines. And they, of course, the American Heart Association, American College of Cardiology, they work very closely with the European Society of Cardiology, so that things are not confusing from one place, from one geography to the next. So they sort of coordinate guidelines, then, so to speak. So again, when we talk about mitral stenosis, so if this is the normal scenario, this is the left atrium, the mitral valve opens diastole, blood flows into the left ventricle. When the valve is stenotic, it doesn't open well, and the blood doesn't flow out freely, so the left atrium dilates, and there's a back pressure that goes all the way from the pulmonary veins to the pulmonary arteries and lungs. So again, mitral stenosis, the valve doesn't open properly, dilates the left atrium, it's the left ventricle there, okay? And so rheumatic mitral stenosis is the most common, as we have said before. So you get thickening, and thickening is predominantly at the leaflet tips. The valve is rigid, immobile, and also the cords. So not only the valves are involved, but the cords, the subvalvular apparatus. And again, you get the hockey stick configuration, and that's because of commissural fusion. You get a large left atrium. So these are the current numbers, okay? Well, sorry. Yeah, well, these are the current numbers. So this is the current guidelines. So these are the current guidelines, and so we have mild, moderate, severe, and a very severe. So there's a very severe category. And we not only look at the mitral valve area, we look at the pulmonary pressure, the systolic pulmonary pressures, and the mean gradient across the mitral valve. So the things that we look at: mitral valve area, the mean gradient across the mitral valve, and the pulmonary artery systolic pressure. So let's look at very severe. So what we used to call severe is now reclassified as very severe. So a mitral valve area of 1 or less, so less than 1 or less than 1 centimeter squared is very severe. Mean gradient greater than 5 to 10 is very severe. And the pulmonary artery systolic pressure greater than 30 is also reclassified as very severe. Severe is if it's less than 1.5, less than or equal to 1.5 centimeters squared. And the gradient between 5 and 10, your pulmonary artery systolic pressure greater than 30, okay? So we used to call this mild. So, we jump from mild to severe, and then there is a very severe category. Mild and moderate, if you see they have look like they have the same numbers, but what they have further reclassified all valvular lesions, and they talk about symptoms. So symptoms is big. So we talk about patient at risk, patient with structural disease, patient with severe numbers like this, just a numbers thing, and then patients who are symptomatic. Because a lot of time we don't intervene in these patients until they are symptomatic. So you need to know the table, but symptoms are very important. Okay, so you have to make a combination of the numbers with symptoms. Again, patients with mitral stenosis, sometimes you have to exercise these patients because they will come, you know, sometimes they're symptomatic with exertion. When they walk or they go up steps, they're symptomatic. They come to the office and they line on the echo table and you do your measurements. You're going to get numbers that don't look too bad. Okay, so you might get a mean gradient looking like this. Okay, so of course you're going to trace it to get the mean gradient, and then this is the TR jet, and you trace to get a peer pressure. So at rest, these mean gradient and the pulmonary pressures may be very reasonable. But once you exercise the patient, minimal exercise, you can see the gradient goes up tremendously. When you trace this, you probably get a mean gradient greater than 15 millimeters mercury, and then you can see the jet increase. So therefore, the pulmonary pressures also increase. So especially patients with mitral stenosis, a lot of time they will come to you and they will tell you, but doc, I'm not symptomatic. That is because they've slowed down. The disease has sort of slowed them down. So instead of walking brisk, they're walking extremely slow. So they're not symptomatic. If they were to walk briskly, then they will become symptomatic. So you have to exercise them. Okay, we talk about the conical shape of the valve because of the commissural fusion. So if you plane this area, which corresponds to this, you're going to get a large area. Remember, the restriction is at the tip. So this is the area you want to plane. So, okay, so the pressure half-time method, we said 220. If the patient is in atrial fibrillation, you want to do 5. These are some of the limitation of the pressure half-time method. It's if the patient have significant mitral regurgitation. So remember, this is all flow. So if the patient have significant mitral regurgitation, you have a lot of blood going into the left atrium. So in diastole, you're going to have a lot of blood coming out. So significant MR can affect it. If the patient have increased LV filling for whatever pressure, because it's a pressure difference that you're looking at, the pressure half time, or there's a sudden change in the relationship between the LV and the LA compliance. So if you do your balloon valvuloplasty, then that can affect that. So when the patient comes to you for evaluation, and you want to determine if this patient is a good surgical candidate, you're going to look at a number of things. And the European have their Euro score. In the United States, we have the STS, the Society of Thoracic Surgeons score. And in addition to looking at the valve, we look at the frailty. If the patient is very cachectic and stuff like that, is there other organ system that are compromised? And then we look at the valve itself. Is this an easy fix? Yes or no? So we have to look at the total picture, because all of these things are going to affect mortality. And the bottom line is mortality. You have to fix the valve, but you have to save the patient. Remember what we said about the 2014 guidelines. in addition to looking at numbers, mild, moderate, and severe, we have stages. We look at these valves and we assign a stage to the valve. Stage A just means the patient is at risk of developing mitral stenosis. Patient had a history of rheumatic fever and rheumatic. You can get an inflammation of the valve at the time of the thing. So the patient may have a little mitral regurgitation when they had the rheumatic fever. So these are patients just at risk, stage A. Stage B, asymptomatic patient with progressive. So remember, we have the mild and moderate, and they have similar numbers. So mild to moderate patients, and they're asymptomatic, those are stage B. Then patients who are asymptomatic but have severe numbers, they're stage C. So the severe patients who are symptomatic, they're stage D. These are that need to be fixed. All right. So class 1 recommendation for someone who comes with MS, of course, you're going to do your echo. You're going to do your transthoracic echo. That's your initial evaluation. And with the transesophageal echo, you're going to look at the hemodynamic severity, which is the mean gradient. You're going to look at the mitral valve area, pulmonary artery pressure. So those are the things that you want to look at: mean gradient, mitral valve area, and the pulmonary artery pressure. Patients with rheumatic fever, you can do your pressure half-time. Patient with senile degeneration of the mitral valve, you probably should do continuity equation. You're going to look at you're going to look at the other valves to see if the other valves are pathology. So you're going to do a complete evaluation. A TEE, a transesophageal echo, if you plan to do a percutaneous mitral balloon commissurotomy, because you have to make sure that there's no blood clots in the left atrium and in the left atrial appendage. And then if the patient have mitral regurgitation, the TE is very good to further elucidate the mechanism of the MR could maybe a different mechanism, and the severity of the MR. So TE is a very important part of your workup of these patients. Again, your patient who comes to you, and when you do your numbers, the numbers doesn't look too bad, but they tell you that they have shortness of breath when they exert themselves. You have to exercise those patients. And then when you exercise the patient, you're going to look at the gradient, the mean gradient, and the pulmonary artery systolic pressure. See how it goes up tremendously. Again, these patients tolerate atrial fibrillation poorly. Any type of increase in heart rate. And one of the things, when they exercise, the heart rate goes up. And because the heart rate goes up, the mean gradient goes up, and they become very short of breath. So some of these mitral stenotic patients may be doing very well, but they go into atrial fibrillation and they decompensate. So if you have a patient that you've been following, and all of a sudden they call you one night and they can't breathe, you are more sure, 100% sure, that they went into atrial fibrillation. Okay. So you want to anticoagulate these patients. So if the patient have mitral stenosis and develop atrial fibrillation, you want to anticoagulate them, but you want to use warfarin. If the patient had a prior embolic event, you also want to use warfarin, or if they have left atrial thrombus. So patients with mitral stenosis who develop atrial fibrillation, you cannot, in the United States, you cannot use the direct oral anticoagulants. the recommendation is warfarin. So MS and atrial fibrillation, MS prior embolic event or left atrial thrombus. So these are updated guidelines. Okay. And you know, patients with MS who goes into atrial fibrillation, you should try and convert them back to sinus rhythm. So, because if you don't, they're going to still be symptomatic. And not only that, but that's an indication for surgery. So if the patient have MS and they develop atrial fibrillation, that's an indication for surgery. Okay. So, if you have a patient with stage D, so remember we talk about stage A at risk, stage B is your progressive patient, your mild to moderate MS. Stage C is the patient who have severe numbers, just from a numeric, and they're asymptomatic. Your stage D is your symptomatic patients. So we talk about the percutaneous mitral balloon commissurotomy. You do your Wilkins score, and Wilkins score is less than 8. You can go ahead and do it. Of course, you want to make sure that so this is your class 1 patient. They have severe numbers. So remember, severe number, the valve area is less than or equal to 1.5 centimeters squared, and they shouldn't have any contraindication um, uh, to doing. Remember, you have to do your T. There shouldn't be any blood clots, and then you can go ahead and do it. You can do surgical intervention. Patients with class 3 or 4 symptoms, or once they don't have an eye surgical risk, the STS risk we use in the United States, and if they are not a candidate for percutaneous mitral balloon commissurotomy, or if they had a failed procedure, then you do surgical. You essentially replace the valve. So again, contraindication to percutaneous mitral balloon commissurotomy includes if they have a large valve area, then you're probably not going to open it more than 1.5. The balloon valvuloplasty or commissurotomy is not going to help them. If they have a thrombus in the left atrium, if they have more than mild MR, so we're looking at the Wilkins classification to some extent. If they have more than mild MR, if they have severe bicommissural calcification, the absence of commissural fusion, if they have severe concomitant aortic disease. Because if they have significant aortic disease, you have to fix that too, so the patient need open heart surgery. So it don't make any sense you fix the mitral valve and then leave the aortic valve. So if they have other valves involved, you have to go in and do it. So these are just some recommendation of the different type of procedures you can do. Looking at the American Heart Association and the European guidelines. So class 1 for the AHA-ACC, if the patient have concomitant valve surgery, if the patient have severe, so if they have stage C and D, which is severe MS, remember stage D is the patients who are symptomatic. If they're going to undergo other cardiac surgery, say they're going to undergo bypass surgery. So if the patient is going to undergo any open heart surgery, if they have stage C or D MS, then you just replace the valve, okay? Then you can do your percutaneous mitral balloon commissurotomy if the patient is asymptomatic with very severe, so not very severe MS. So if they're asymptomatic, is going to put them in a stage C because your asymptomatic patient with severe MS is stage C. But if they have very severe numbers, you can do your balloon commissurotomy. The valve morphology have to be favorable, however, no LA thrombus or clots, and they shouldn't have significant mitral regurgitation. So, you know, the updated guidelines just look at the numbers, and so once the valve area is less than or equal to 1.5 centimeters squared, that classifies the patient as severe. And of course, the corresponding gradient is 5, anything greater than 5, okay? The pulmonary artery systolic pressure greater than 30. But we also have a staging system. Stage A, just at rest. Stage B is your progressive patient with, the mild to moderate. And then your stage C, patient with severe number but asymptomatic. And stage D is your severe patient who are symptomatic. So those are the updated guidelines. Okay, so we have covered MS. On Thursday, we look at the regurgitant lesions, the updates for the regurgitant lesions.